Good afternoon, everybody. I'm Anna Plotkin, Director of Continuous Professional Development at the University of Toronto, and we are starting our June Community of Interest in Breast Pathology. Before we're starting, I will ask kindly everybody to mute your microphones, and another ask to send us evaluation at the end of this session. Everybody will receive a link, and we're looking very seriously to improve and consider future events based on evaluations. Today, the session is moderated by Dr. Rachel Han and Dr. Jessie Wu. Jessie and Rachel, we're looking forward to this session, and the floor is yours.
Good afternoon, everyone. Welcome to the Summer 2025 Breast Community of Interest meeting. Thank you so much for joining us. My name is Jessie Wu. I'm a breast pathologist at St. Michael's Hospital in Toronto. And in the meeting with me, my co-host is Dr. Rachel Han at Sunnybrook Hospital. We have a very exciting program for you today. We're going to start the meeting with a lecture from Dr. Miralem Mrkonjic from Mount Sinai Hospital entitled, "When Not Everything Is What It Seems." I bet you're all very intrigued by this title and perhaps a little bit perplexed. I'm not going to give you any spoilers. Rest assured, it'll be fun, very educational, and very useful for your daily practice. And as per our usual format, the lecture is going to be followed by a Q&A session afterwards, and then we'll have presentations of interesting cases following on. So it's a real pleasure introducing Dr. Miralem Mrkonjic. Those of you who attend Breast Community of Interest meetings regularly know that he's a frequent contributor and he's an excellent speaker. Miralem is a staff pathologist and a site director of breast pathology at Mount Sinai Hospital. He's a member of the Women's Health Group focusing on breast and gynae pathology. He completed anatomical pathology residency training at U of T, followed by a breast pathology fellowship at University Health Network. His research interests involves discovery, development, and utilization of prognostic and predictive biomarkers in breast and gynecologic malignancies. And he's currently involved in national ring trials in harmonization and standardization of HER2-low and Ki-67 testing in breast cancer. We're so pleased to have Miralem here with us today, so please join me in welcoming Dr. Miralem Mrkonjic.
Thank you, Jessie, for that kind introduction, and happy summer, everybody. Hopefully everybody's keeping cool and hydrated. Apologies to anybody that's attended ASCAP Path Update or watched the lectures online, because you would have seen some of these cases. The reason I chose them, because I thought they were very interesting, not something that we always see necessarily, but some of them could also kind of lead us down the wrong path. So I have no conflict of interest to declare relating to this lecture series, and AI was not used to generate any parts of this presentation. So for the case one, it's a 45-year-old woman without any relevant clinical history. There was a palpable mass in the right breast. It was clinically identifiable and palpable, approximately 2 centimeters in size. Because it was superficial, they decided to do a punch biopsy in the clinic, as they frequently do here, and the pathologist signed it out as a xanthogranuloma. So a surgical excision was performed based on the OR node, predominantly because the symptoms of the patient and they wanted to take it out. So it came to me. And just looking at this kind of on the low power, it really does look that this is really superficial. We're looking at predominantly skin with this dermal, mass that's extending into some of the subepidermal adipose tissue, and pretty much looks like a mix of some of these larger, lighter pink cells and possibly some more of the, inflammatory cells deeper down. And when we look at the intermediate power, it's like, yes, we do see a lot of these, large cells with abundant eosinophilic cytoplasm, admixed with some of the chronic inflammatory cells. And then when we go on even higher power, it just confirms what we've seen on the medium power, lots of these really large plump cells. When you do start to pay attention to what's actually happening in the background, you notice that some of these chronic inflammatory cells are a mix of both lymphocytes and there's some plasma cells, and some of them seem to be meandering through the cytoplasm of these really large plump cells with some of these really pale halos around them. And that was pretty much like one, the main important part of the diagnosis here, identifying enteropoiesis. So I saw this, ordered a couple of stains, and just showed it to my hematopathologist to confirm the diagnosis. And it was the first time I have made this diagnosis as a staff pathologist, although, you do come across it as a resident. So CD68 was diffusely positive in these large plump cells, as was the S100. So this one is an example of a Rosai-Dorfman disease, which is a known Langerhans cell histiocytosis. And it appears in either one of the three forms. It can be classical, which is just nodal, can be cutaneous, and if it's cutaneous only, it's considered self-limiting, or it could be disseminated, which is aggressive, and those are the ones that usually require additional therapy. Third of the cases do have alterations in MAPK or ERK pathway, and they're associated with a variety of autoimmune conditions, systemic lupus, idiopathic juvenile arthritis, or hematologic anemias, as well as lymphomas, myeloid neoplasms, and IgG-related conditions. And obviously, management will vary depending on the symptoms. As I really did not have any clinical history for this patient, nor any of the serology, obviously, the diagnosis had to be accompanied by a fairly lengthy comment saying, this could be just a single cutaneous thing, but it could be disseminated, and it's associated with all these other things. And then clinical, radiologic, and serologic correlation is required. So how does this thing look like on the microscope? As I've shown, it's accumulation of these really large histiocytes with abundant eosinophilic cytoplasm, and enteropoiesis is like the main key finding, which is just engulfment of these large intact inflammatory cells that are predominantly just traversing through the cytoplasm. No two-tone giant cells. Obviously, when you hear of xanthogranuloma, Erdheim-Chester disease, one thing that kind of pops into your head. So it's, as I've shown, it's positive for CD68, CD163, S100, cyclin D1, and OCT2, and it's negative for Langerhans CD1A, because the other differential would be Langerhans cell histiocytosis. So as I mentioned, first time I've seen it in the breast or the skin of breast or being anywhere close to breast. So I thought it was an interesting case to share. Now, a couple of months later, I received this case. Similarly, 45-year-old woman, but she's had a history of right invasive lobular carcinoma. It was classic type, so intermediate histologic rate, your usual 3-2-1 pattern, and she's had a lumpectomy, sentinel node biopsy, and then radiotherapy. So she was PT1 CPN 0 for her final staging. And then during the follow-up, they noted that she had a contralateral, so left, lymphadenopathy. Interestingly enough, left breast imaging was completely unremarkable, and they performed needle core biopsy for diagnosis. And as the usual requisition, just as rule out everything under the sun from, could this be benign? Is this lymphoma? Is this metastasis? And so on. So this is pretty much what the specimen looked like on lower power. We have this one piece, which does look like it could be lymphoid tissue, or at least it has a lymphoid predominant background. And then there's this prominent, again, involvement by some of these larger cells with more eosinophilic cytoplasm. On intermediate power, you do note it's, yes, larger cells, kind of irregular nuclear membranes. Maybe there's some grooves around, and prominent eosinophilic cytoplasm, and pretty much more of the same on the higher power. And yeah, some of the grooving was fairly prominent, irregular nuclear membranes. You don't really appreciate any intercellular borders. So I thought, okay, this is interesting finding. I usually just order one immuno in these cases, and then I showed it to my hematopathologist again, just to kind of get his opinion on the case. And a couple of days later, it's like, well, that case you showed me, it's really hard to pinpoint what exactly is going on. But luckily, by that time, I did get my one immuno back, and that's generally one immuno that I order when I'm dealing with some of these cases that was pancytokeratin. So it was diffusely positive. It was also diffusely GATA3 positive in these cells, and ECAD was completely negative. So this was a case of a metastatic mammary carcinoma. Pretty much it's a metastatic lobular carcinoma histiocytoid variant, which is why both my hematopathologist and I were just looking at each other and be like, really, these are epithelial cells? It's keratin positive. But it represents contralateral axillary lymph node metastasis, which is a fairly rare thing to see. And they come in two forms. It's either synchronous or metachronous, which tends to be more common. And we do see this occasionally if there is, either an incidental finding on invasive cancer, and then they go back in to try and match the lymph node, usually due to aberrant lymphatic drainage. Sometimes the lymph nodes will be mapped to the contralateral side. And if it's synchronous, it's usually part of more disseminated disease. Either way, it's classified as distant metastases per the 8th edition of the AJCC. Now, if you look at the literature, there's some evidence to show that when you have isolated contralateral axillary met, prognosis is better than your run-of-the-mill stage 4 disease, and maybe it should be treated with curative intent. And other studies show that, no, it does behave at distant metastases, and I think it mainly matches to whether you're dealing with more of a synchronous metachronous disease and what's the disease burden overall in the patient. But I'm really curious to see which way the AJCC is going to, if they're going to try and make a separation in their next round, next edition, or they're just going to keep it as, we just classify these as distant metastases. I heard that this case has been kind of out there tormenting our residents in training because it was such a interesting presentation and not just clinical presentation, but also due to its histology. So case 3, as you can tell, I made everybody 45-year-old, mostly for patient identifiers. There was a mass lesion in the left breast, 3 centimeters. It was palpable. There was an architectural distortion on imaging with a normal axilla, and needle core biopsy was performed. We have no other clinical history available to us. So the section showed multiple cores of tissue. Predominantly, we see this, maybe some fibrous tissue, and then there are these more cellular areas on lower power. And then when we go on higher power, we can actually see that, there is what looks like a chronic inflammatory infiltrate, and it's surrounding either some small vessels or even some breast ducts. And here's a bit more of the same. And then when we start to pay attention in the stroma, we do start to see some of these fairly plump-looking stromal cells, some of them fairly faint, but some of them a bit more prominent. And then obviously when we start to look at the clinical history of the patient and finding out what's happening, I think we found out that she did have a history of diabetes. So while we, were a bit more, I was a bit more vague on the descriptive in the diagnostic line, the comment said that, the finding in the right clinical context could be consistent with lymphocytic mastopathy, which was previously known as diabetic or fibrous mastopathy or sclerosing lymphocytic lobulitis. And it is associated with autoimmune diseases, diabetes, or Hashimoto's thyroiditis. And what we do see is really prominent perilobular and perivascular lymphocytic infiltrate, dense stroma, and these plump epithelioid fibroblasts. And some of the stroma may have some of this keloidal appearance to it. It's generally monitored, may recur if it's excised, but generally it doesn't go straight to an excision. So, a couple of days after this case, a colleague presented a similar case at the consensus round of a patient which does have diabetes and currently on metformin. On lower power, yes, there was a bit of a fibrous component in the stroma. Around the breast ducts, there was some collection of more chronic inflammatory cells. And yes, there were some fairly plump-looking cells in the stroma. So kind of had a somewhat similar picture, but not quite as prominent in terms of chronic inflammatory collection. And when we look at the other areas, stroma wasn't as keloidal or sort of as hyalinized as you would expect it to. And some of these cells, yes, they were fairly prominent and plump. And this is just additional parts of the stroma. So, the recommendation was just do one stain and maybe sign it out descriptively, depending on what the stain showed. That stain was pancytokeratin or A1, A3, and then pretty much what it showed was this, diffuse infiltration of single discohesive looking cells. Let me just go to the next slide to show that the E-cadherin was completely negative, and we had some really good internal controls. And interestingly enough, ER was also negative, as was PR and HER2. And then we did the GATA3 and TRIP stain to show that these actually do light up, and these are of breast origin, that this is not coming from, gastric or some other site. So we usually teach our residents, when we tell them name 3 breast cancers that are always ER positive, and they usually just rhyme off, tubular, mucinous, lobular. I didn't show the other case, but every now and then we do see one of these lobulars that surprise us being ER negative. We do work them up to prove that they are actually breast. Most of the times, if we do see them, they're either the histiocytoid variant or they may have like really predominant apocrine features. So it's interesting to see. And then additionally, I did have a mucinous that was also ER negative. And I do not expect I'll ever find a tubular one that was ER negative. So the case 5 was a mass lesion, left breast, 4 centimeters, obviously clinically palpable. It defined on imaging. There was normal axilla, and needle core biopsy was performed. And it the case was sent to us as a consultation to help classify a fibroepithelial lesion. And this is what the lesion looks like on a needle core biopsy. I can see why it was raised as possibly fibroepithelial lesion. It does have some of the normal breast ducts, which predominantly appear entrapped within the tissue. And even on the lower power, it kind of looks like we do have some kind of perhaps spindle cell proliferation. On a bit medium power, we do see the entrapped ductal structures. And there is this kind of either disorganized or somewhat, vague story form architecture to the growth of this. On a higher power, what we do see is, yes, these lesional cells, some of them really do have this, dominant granular eosinophilic cytoplasm. There is a chronic inflammatory cells in the background, and one specific type that really starts to catch eyes in these really clusters and individual parts are plasma cells. So there's quite a number of plasma cells in the background. Here's the entrapped normal breast ducts, which look completely normal. And then again, whichever field you do look in, you start noticing these plasma cells around. So a couple of things that were performed. IgG, which highlighted some of these plasma cells. And then more interestingly, IgG4. I tried to match the area so you can actually appreciate the ratio of IgG4 to IgG, and it was well over 40 or 50%. Now, as these usually don't get excised, we did have a case a couple of years ago that was excised, and this is pretty much what it looked like on lower power. It was fairly well circumscribed, some fat entrapment, and then some of these lymphoid collections in the background. So this is IgG4-related sclerosing mastitis. It may represent as a part of our IgG4-related diseases, which includes 1 or more organs, serologic abnormalities, and 2 of the 3 of the pathologic features, which include dense lymphatoplasmacytic infiltrate with fibrosis. You get either more than 10 IgG4 plasma cells per higher power field or IgG4 to IgG ratio greater than 40%. The background has storiform fibrosis or obliterative phlebitis, which I have never seen in breast. And scanning through the literature, it has never been reported in the breast. However, it is part of these pathologic features that are part of it. Perhaps there needs to be one that is breast specific. And prognosis depends on the systemic involvement, so what other organs might be involved and so on. And I think the final case that I have for you is a case of a woman with prior history of right invasive lobular carcinoma, classic type. So 3-2-1 pattern, intermediate grade, PT2PN0. She's had her lumpectomy, sentinel node biopsy. And then they noted a prominent right axillary lymph node. So it is ipsilateral lymph node that was prominent while she was being scanned for radiotherapy. And core biopsy was performed to rule out a MET because they're worried that maybe they didn't catch the proper lymph node during the surgery. Requisition was marked as stat because they wanted to know exactly what the management will be. And usually these stat cases arrive to the person who's usually, either in a rush or about to go on a holiday. So it was a Friday, and I've asked the colleague to just give me the case to complete the sign out. So this is what the needle cores look like. There was quite a bit of this, what looks like fairly necrotic material in the background. And then we have some fibrosis and maybe some collections of lymphocytes or lymphoid tissue to be exact. And at the very tip of one, there is a collection of cells that look different. And when we get to the higher power, they have this kind of appearance to them. They look somewhat discohesive, a bit more, plumper eosinophilic cytoplasm. And, it was ERPR, HER2 negative, but it was ECAT positive. So it was different profile to what she had in her breast, which was, run-of-the-mill invasive lobular carcinoma, which is ERPR positive, HER2 negative. So then the question was, well, why don't we go and prove that this is, actually breast tissue? GATA was negative, but SOX was positive. So we do know that minority of, high-grade triple negative breast carcinomas that are GATA3 tend to be SOX10 positive. But this was such an unusual presentation, we didn't want to just stop there. So pancytokeratin, and as you can see, tissue is getting smaller and smaller. So I was just kind of praying that it's going to survive my complete workup. Pankeratin was negative. HMB45 showed some patchy positivity, but MART1 was diffusely positive. So this was a case of metastatic melanoma. Patient had no history of melanoma. Clinically, no suspicion lesions were mentioned on any of her physical exams. So this was one of those cases where the metastatic diagnosis was her first diagnosis of her case. So mets to the breast are fairly rare, and they generally are under 1% of all breast malignancies. And they're usually in a setting of systemic involvement. In terms of hematological malignancies, they're even more rare. They tend to be in older patients, advanced disease stage. Third of the presentation, like this case, this was their very first presentation of the disease. Most common sources, if you're looking at lymphoma, leukemia, melanoma, carcinoma, in younger patients, rhabdomyosarcoma, malignant mesothelioma, neuroendocrine tumors, and cervical squamous cell carcinoma. Most common carcinomas tend to be pulmonary, so lung, ovarian, gastric, prostate, RCC, and colorectal. Oddly enough, we did have, in a short span of time, one that was lung, followed subsequently by another case that was colorectal carcinoma, followed very shortly by another one that was a high-grade serous ovarian carcinoma. So these things did appear in a cluster. Usual hints to kind of expand your workup is if you have an unusual histology, and that's kind of hard to explain in the breast because invasive ductal carcinoma, no special type, can have so many different morphological appearances. But when you do have a lack of in situ carcinoma, and when you have extensive LVI, when it's triple negative, they sort of perk you up to be like, okay, let me just expand my IHC profile just to show that this is actually breast. And one of the reasons why we ended up validating both mammoglobin and TRIPS at our site, because dealing with a very challenging case of a urothelial met to breast, which, GATA3 was not very helpful, and CK20 positivity was the only kind of big hint that this was something else other than breast. Clinical history is extremely helpful, but we don't really get that often when it comes to requisitions, or even when you look at the clinical history, it's usually just how the thing appears on the radiology or clinically, but past medical history, a patient had this and this and that rarely ever happens. So I think that's the end of my cases, and we can go into questions or discussions.
Thanks so much, Dr. Mrkonjic. Those were amazing, very, very challenging cases that you showed us. Thank you so much. And as mentioned, we can have a time for any questions from the audience. Yes, Dr. Nofek-Moses.
Thank you, Miralem. This was an excellent presentation, and also demonstrates how the life of a breast pathologist is way more complex than just invasive ductal DCIS and invasive lobular. I wanted to ask you a question related to the TRPS1. You did mention that you find it useful and more specific when it comes to differentiating from urothelial. But I do remember that a couple of years ago, I attended a conference and they said that there is some technical difficulty in setting it up, and the vibe was not very positive. So I actually wanted to see if you had encountered anything like that. And also in terms of the sensitivity, how do you find it in comparison to GATA3? I understand that it's probably more specific.
Yes, that's a good question. So we did concomitantly mammoglobin, because we didn't have that at our site, and we did TRIPS1. And so it was interesting to compare, because we performed them on the same set of cases, and it was picking up a lot more cases than mammoglobin did. And then as part of our general workup, because TRIPS1 is still, it's kind of like, it's being touted as being great, but we still don't have a full profile exactly what else is picking it up. And then a couple of places where we did see it was prostatic tissue, as well as skin adnexal tissue. And I know it's been reported in sarcomas, osteoid or chondrosarcomas. So I feel like more we know about it, the better we can be in utilizing it. That being said, it's not positive in urothelial, so it's great when you have that GATA3 positivity. So far, we've seen it wherever we see our GATA3 positivity. In terms of setting it up, we didn't have too much of a challenge getting it to work. I think it just took a couple of rounds of optimization. But as I mentioned, we've seen it a lot better. It seemed to be a lot easier to optimize than mammoglobin was, surprisingly enough.
Thank you.
Another question from Dr. Mulligan.
Thanks, Rachel. Thanks, Miralem. That was excellent, and interesting as always to see how big a role lobular carcinoma plays in these tricky cases. And I would say, in many of my near misses, at least that I know about, lobular played some sort of role. I have a question about the second case, so the metastatic lobular to the contralateral axilla. So we've had a couple of cases of that recently, not ones I've reported, but ones that I've encountered. And I just wanted to ask you two things. Firstly, are you, if on an excision specimen, are you selecting M1 in these scenarios if there's a history of contralateral lymph node dissection or a sentinel node? our surgeons tend to consider this local regional disease rather than truly metastatic in that setting. So I was wondering, I'd be interested to know how you're approaching it. And the second question was just about the morphology. So I'll often look for those intracytoplasmic lumens with what looks like little blob of mucin for ILC, and particularly in, I guess, in the metastatic setting. Is it reliable, or do I always have to do immunos?
Well, this was the case where, I was trying to find any evidence, because both Carla and I were just looking at each other, be like, really, this is what it is? Because we were both convinced this was histiocytic. This was some kind of a histiocytosis or some kind of process. So I was surprised looking at it over and over again and be like, I don't really see anything that was your, typical description of lobular, looking for intracytoplasmic mucin and globules, and it wasn't as prominent as you would hope or find them generally. Few cases that I did have, and few cases were, as I mentioned, it was a case where, case of DCIS, and there was incidental carcinoma. They didn't do sentinel node. They went back to it, and one of the nodes was mapping to the contralateral side. Those cases were a bit easy because they were negative, but one case that I did have that was positive, actually, had to write a comment that, based on the staging, these are stages of the M disease, but it was just one node that mapped to the contralateral side, and it was a positive node. And in terms of it just being a sentinel node that's positive, there's evidence that showed that it's just going to behave as a local regional nodal disease, and then kind of just leave it to the clinician. I did describe why I selected M in the synoptic report for that reason. It was in the comment. Just if we're going to go stage it by the book, as AJCC says, this is what we're staging it as, but still giving the clinicians the context of, what is happening. And I want to say, was it one of the radongs from PMH contacted me about that, about the comment, which was interesting because, we usually wonder if clinicians read our comments at all. But she did, and she made a comment because one of the surgeon, I think, sent an email afterwards asking for me to clarify more, and then she chimed in and restated, and then was like, oh, okay, now it makes sense.
Yeah, I think the important thing is to make sure that the message is conveyed and that you make them read the comment. So that's probably one reason.
Yes.
Pick up M1, they don't assume it's, ipsilateral. I also have a question about your last case. On core biopsies where you're not seeing DCIS, in what situation do you always do one or two extra immunos just to prove it's primary, or what's your approach? I feel like I'm doing all these immunos now on invasive ductal carcinomas, but just in case, does turn out to be a rare met. So what do you recommend?
When they're triple negative, it's my extra kind of like, okay, I'm just going to do the next round and just add a couple of extra biomarkers. You feel so much better when it's like, oh, it's ER/PR positive, or it's ER positive and, HER2 negative, or it could be, then you feel a bit more comfortable with it. But when it's like triple negative, and especially if it's an older patient, then I'm always like, I'm not clicking that sign out button. I'm just going to add a couple of more immunos. An extra day is not going to make that much difference in terms of a clinical management, but it could make all the difference if you pick something else up. So for that reason, yes, then I will add CK720, and then, to confirm that it's breast. Now we have TRIPS and GATA. If it's like a lower threshold, if it's something that's like really super ugly, then my second panel, or even as a first panel, would be to just include other sites as well. So I may include like PAX8 and TTF1 and CDX2.
I guess at the very minimum, I tend to do a PAX8 and a GATA3 just because, a lot of the gynae ones could be hormone sensitive, but our turnaround time for IHC isn't always the fastest. So I might order too much up front just so that I'm not continuing them to wait for the next steps. Great.
Yeah, I feel like you need to optimize it to how your site works, with us, they'd be kind of like, oh, if you order it before 1, you'll generally get it the next day. Doesn't always work, but most of the time it works. So I kind of feel like, okay, it's just going to be 1 extra day. But yeah, like you mentioned, gynae ones could be a problematic. And I did have a case where patient did have a mastectomy. She's BRCA positive. She had invasive ductal carcinoma. And then there was a supraclav node that was positive, and they were just convinced this was a breast recurrence. And then as soon as I looked at it, I was like, oh, this looks different. But, it was ER positive, but it was also WT1 TP53 overexpressed. So that was her presentation of her high-grade serous ovarian. But yeah, gynaes, you need to keep those in the back of your mind.
Thank you.
I also had a question to follow up on TRIPS one, and maybe you covered it already in your previous answer already, but have you run into any cases where, let's say you're ordering your breast origin panel up front and TRIPS one is really the only marker that's staining positively, and in those cases, do you then sort of favor breast origin, or do you kind of leave a differential at this point?
So far, luckily, they've always been always positive with, GATA3 so far. Because when we just first started order, we'd always just order along with another breast marker just to make sure that we don't just use it on its own. But if my GATA3 and SOX and it's triple negative and TRIPS is the only thing picking it up, then yeah, I would make a comment favor breast based on the findings, as long as my other workup was also negative. So, if you prove that it's cancer, but it's, not your gynae, not your lung, not colon, not somewhere else, then you can say favor breast. But yeah, that's the kind of scenario I haven't seen yet, but I'm pretty sure it's a matter of time. If it's a man, then I don't think we have additional, as I mentioned, we found it positive in prostate. I'm not sure if it's been what the percentage of prostatic adenocarcinomas are positive for TRIPS. If it's a man with breast cancer and it's, again, triple negative and TRIPS was the only one, then I would have to send it out for more workup if we didn't have any other immunos.
And then I also had a quick question about the 2 cases, the Rosai-Dorfman and the IgG4 sclerosing mastitis, so super rare. Just curious to know if for either of these cases, was this their first, like the breast was the first presentation of disease, or like was there a known history? Because in my opinion, I feel like without the history, these are very difficult diagnoses to make for the first time in the breast, given how rare they are.
Yeah, it was the first time, so there was absolutely no history for both. So, which is why for the first one, I went over to our hematopathologist and I was like, can you please confirm that before I click sign out that you do agree that this is Rosai-Dorfman? And he said yes. So that one came with a lengthy comment explaining, without us having any clinical history, we can't tell if this, where does this fall into? Is this just like, just her dermal presentation? Is this part of more systemic that we don't know about? Now that you mentioned that, it kind of makes me want to go back and follow up and see did they do additional workup on the patient, and was there any other clinical history that we didn't know at the time. IgG4 one was, we've when you have the histology, it's kind of easier to go along when you have all the features present, and then especially when you have your also ratio, either calling it out or favoring this, and then putting in the comment why you're favoring it. Because we did have a few cases where it's kind of like, oh, it's sort of, because you can argue story form architecture is kind of in the eye of the beholder at times, and sometimes it can be fairly just disorganized. In those cases, it would just be like, this is one thing in the differential diagnosis, and then like serological correlation is also required, and then see. But I haven't followed up with that patient either yet, although, the histology was it ticked all the boxes, at least for that case.
For sure. Awesome. Great. Thank you so much. Again, very amazing cases. Thank you so much for sharing them with us. I don't think we have any other questions in queue, so we'll move on now to our, oh, sorry, there was one last question in the chat. So there's a question, how do you exclude adnexal lesions in the unknown metastasis scenario?
That's a good question, because it wasn't even in a metastatic scenario. It was a breast excision that a colleague of mine received, where it didn't have the typical breast look to it, but it always raises one of those unique subtype differentials, like it didn't quite look adenoid cystic. So one of the top in the differentials, could this be adnexal? And unfortunately, as we mentioned, like GATA3 and trypsome may not necessarily help you in the adnexal setting. And if it's one of those special subtypes, then your usual biomarkers will not work either, because when they're lower grade, they tend to be triple negative as well. So this was a case where we favored it to be adnexal, and they sent it for expert dermatopath, who then agreed with the case. So this was just one scenario where we recently had that kind of a question, but it's a really valid point, because regardless how many biomarkers you have and you develop, sometimes they can't give you a full picture. Obviously, if mammoglobin worked and it was positive, it'd be great. Or if breast or GCDFP15 works, they're great when they work, but when they don't work and you have something else that they cannot exclude in terms of your other markers, then it becomes really challenging.
Great. Thank you so much. So thank you again, Dr. Mrkonjic, for your great presentation. And we'll move on now to our first case presentation for the afternoon. And this first case will be presented by Dr. Kevin Kwan from South Lake Health.
Hi. Okay. Hi everyone. So my name is Kevin, and yeah, I'm one of the full-time staff pathologists working in the South Lake Health Market. And today I'm presenting this particular case, not in the sense that it's super rare or interesting like Miralem just presented, but I think it's a good learning case for me and for many of the training out there, just as in terms of the way it's being worked up and how it's signed out at the end. So I have no relevant conflict of interest. So just briefly about the patient, this is it's a 91-year-old lady who presents with a growing breast lesion. It's on the right side. She has history of multiple cancer, including endometrial and colon cancer and squamous cell carcinoma of the skin, but there is no history of breast cancer, and there is no relevant family history. This is the mammography. I mean, I'm not trying to play to be a radiologist, but as everyone can see here, there's fairly distinct heterogeneous dense mass that they mentioned to be about 2.4 centimeter. So without much delay, they quickly did an ultrasound guided biopsy of this particular lesion. For the core biopsy, we got two pretty nice juicy core. As you can see on the low power here, the breast biopsy basically shows this spindle cell proliferation. And it might not be illustrated well, but as a whole, this thing looks like it's fairly well circumscribed. And on the other side of the breast core, we also see this adjacent low-grade DCIS. Just moving on to medium high power, you can see that this the spindle cell lesion here consists of this fairly blunt, albeit there is some mild atypical atypia. Overall, the cell is fairly low grade to moderate, I would say, and there's a good cytoplasm. These spindle cells, they have quite a bit of this eosinophilic cytoplasm, and they do form this bundles of intersecting vesicles. On one of the edges, I can also see that there's some adipocytes within the lesion, but I think as a whole, this is just the normal adipocyte that's being entrapped by the lesion. Some rudimentary staining that's performed includes A1, A3, which is actually completely negative. And the only thing that's showing up is P63, which actually only stain about 10 to 20% of the lesional cells. And it's, as you can see here, it's not the strongest P63 staining that I was hoping for. One other stain that was showing weird staining pattern is the MSN. This is the resection case, but on the biopsy, it shows fairly similar staining pattern where it just shows this very faint blush. And we do have nice internal control here, highlighting the DCIS. So as a preliminary diagnosis, I signed this out as just spindle cell proliferation without coming in too much. And then I basically send the case out to UHN for help, so that because they have much better staining IC panels. And as expected, they did a nice workup for me. And it's also nice that they help me confirm that the positive P63 that I see is true, and so that they did repeat the P63 I see in their at their center, and it is a lot stronger, and it's about showing about 50% positivity. Some other permanent stain that they work up, which also helps, is the beta-catenin is negative, CD34 is negative, and they also did a Desmond stain too, and which also shows negativities. So this is the consult report coming back from UHN, which helped basically say this is a typical spindle cell proliferation. And they in their comment, they included a bunch of different possible differentials given based on what we can say regarding from the biopsy. But one of the differential also includes metaplastic carcinoma. Mastectomy happened, I think, right after, as soon as they received the final reports. And as you can see here, we do have this fairly well demarcated fibrous mass on level 8 and 9. And by the time of resection, this mass actually grow even more. This is about 3.4 centimeter compared to a month ago. They did the mammography, which only measures 2.4. So on our histology slide, it shows very similar finding as the biopsy, where we have the spindle cell proliferation that's also overtaking some of the entrapping some of the fat, and as well as some benign ductal epithelial components. Here on one of the edges, we see that there's also adjacent low-grade DCIS. And as you can see here, it's also kind of being slowly engulfed by the spindle cell proliferation. What's different from the biopsy is that on resection, I actually find quite a bit of area, maybe account to up to 15% of the area showing some of the enlarged and more atypical looking spindle cells. They even look a little more epithelial. So here's some more pictures showing these more atypical cells. And what's additional is that on the resection, I definitely see increased mitotic rate. This is even higher magnification. You can see it's not that difficult to find. On any given representative section of the tumor, there's actually easily you can find multiple mitosis in any high power field. So just to quickly summarize the finding, still a spindle cell proliferation with scattered atypia and increased mitoses. We do see some entrapment of normal breast tissue. And given this is a fairly unusual or uncommon diagnosis, this case was again sent out to UHN just for confirmation, pretty much for confirmation. And they did agree with us at the end that this is a metaplastic spindle cell carcinoma, given the morphology and the increased atypia, which is a little different from the biopsy. They also perform pretty much the similar panel of stains on the resection, and they all show similar workup. And additionally, they also did the biomarker, which not surprisingly is ERPR HER2 negative. So I mean, based on what we see here, this is not like the typical ductal carcinoma or the lobular carcinoma that we see majority of the time. Spindle cell lesion of the breast is not that common. And even having that said, whenever we get breast biopsy that shows spindle cell lesion, there's a whole slew of differential that can be that's possible, and what might be making up this particular lesion. So I guess like Miralem was saying before, history is almost always the first thing you look into to see if there's any particular prior cancer, any surgery that can be causing this. And also radiology findings sometimes can be very helpful in terms of the growth, the size and the shape, and also if the growth pattern is well circumscribed or is it infiltrative. Cytologically, if you look at the what kind of cell is consists of the lesion can be very helpful. And from there, you can move onward to to narrow down your differentials. And this was one of the table I found in Modern Pathology, where it's a paper written by Hao and Lee back in 2021, which also talks about spindle cell lesion of breast. This was particularly helpful when I tried to sign out the breast biopsy because it helps me map out like this nice visual roadmap as to where our lesion be what the diagnosis might be for this particular lesion. Okay, so that was basically the case, and I'm happy to take any question. I will try to answer them to the best of my ability.
Thanks very much, Kevin, for that very interesting case. We have one question so far in the chat. Was TRPS1 done on the spindle cell lesion?
I mean, we definitely didn't do it at South Lake, and based on the consultation report, it doesn't seem like it was done.
We don't have that staying here at UHN, so I would say no, it wasn't done here anyway.
Okay.
Kevin, I presume the DCIS was hormone positive.
Yes, the DCI's part was hormone positive. Sorry, I forgot to. I missed out that part because I feel like the spindle cell one is more it's more interesting to look into. But yeah.
Excellent. Thank you so much for sharing that case. So if there aren't any, oh, we have another question from Sharon.
Actually, it's not really a question. It's more about emphasize something here. For spindle cell tumors, particularly those that are not high grade, I think that it's really important to highlight the fact that those are unlikely to respond to systemic neoadjuvant therapy. So if such a case is brought up to discussion with clinicians, this is something to keep in mind, that there is a real importance to classify them as metaplastic carcinomas rather than just a fully differentiated IDC, MSD.
Good to know. Thanks.
Okay, thank you so much. So the next case presentation will be from Dr. Polycarp Erivo from Trillium Health Partners.
Okay, so I'm going to present a 51-year-old patient with a atypical spindle cell lesion. I got this case over a year ago, and yeah, this is the opportunity I'm having to do it. So she's a 51-year-old that presented with a right breast mass detected on screening mammography. On mammography said it was 2.3 centimeters multilobulated. Clinically also, it was about the same size, 2 centimeters. Interestingly, there was no family history in this patient, no history of breast or ovarian cancer, no history of any other risk factors. So a core biopsy was done, and this is the image. Essentially, we see, and this is a very low power image. We see, kind of a mixed population of cells, spindle cells, and then this epithelial cells. I'll just go on high power. You can see some of the epithelial components that they look like entrapped ducts or small ducts. Here you can see a large normal duct. And then we can also see the spindle cell components in the stroma. I think I have a higher power. So this is a high magnification. Essentially hypercellular spindles, stromal components, which is highly cellular, essentially spindled, low grade atypia, if you will. We can see the epithelial components here. They form some ducts with elongated portions. If you look closely on the edge, and you can say these are myoepithelial cells. I believe they are, with the triangular outlook there. This is still another field, still higher power. We can see the epithelial component. You can see the hypercellular stromal component. And just to point your attention to some of these irregular epithelioid proliferation within the stroma. And this at the top right portion of the slide, you can see what looks like, if you looked at this as a resident, you call it a collagenous spherulosis. You can see some basement membrane material within cribriform ducts. Same thing on the left side. So still in the same specimen, we have this osteoid metaplasia. Now it does look like a mature, it doesn't look malignant. So we call it a benign osseous metaplasia now. So the core biopsy, this is just a description from how it was signed out. I kind of summarized it. A fibroepithelial lesion with hypercellular stroma, mild to moderate nuclear atypia, that's in the eye of the beholder. Focal periductal condensation, I really didn't see much of that. There were few mitosis up to 5 per 10 high power field. And then benign apparent metaplastic bone is also present focally. Necrosis is not seen. No stromal overgrowth, no leaf-like architecture, and these were not seen. Now, it's obvious that was a limited core biopsy, so that was added to the comment. Now, the core biopsy also had some immunostains done, obviously, but I didn't show them. I have an excision specimen, which I'm going to spend more time on. But this is just a summary of the immunos that were done on the core biopsy. The epithelial component showed non-atypical pattern of CK5 and ER, essentially telling us that it's benign. And then the spindle cells, triple stain was done, which showed that the epithelial, those ducts that we saw had some myoepithelial cells around them. Also, the spindle cells stromal background was essentially negative for CK5 and P63. So the core biopsy gave a favored differential, but in a favored diagnosis, but gave other differential. So the favored diagnosis was a phylloides tumor, but with the differential of cellular fibroadenoma. Now, this is just a direct copy of the core biopsy diagnosis. Fibroepithelial lesion with hypercellular stroma and metaplastic bone formation. I see comments. So the comments is what I've summarized in the description. So we had the excision. I didn't have the core biopsy. I got the excision and I pulled the core biopsy compared, and the description was fair. On excision, it was this 2.9 centimeter well-defined, what was described as off-white lobulated mass in the breast, and it was a very narrow excision, as we can see, most 1 millimeters from the margins. Now, at low power, we have a well-circumscribed lesion. Obviously, you can see the normal breast tissue on the lower right portion. And then we can see the lesion. At low power, this will tell anybody that at least you can see, stromal components or a cellular stromal component and epithelial components. Oh, this came out of the screen. Well, this just showed a portion of the a tumor, just beyond the tumor, just at the edge of the tumor, you can see some adenosis looking kind of proliferation. At slightly higher power, we can see the same thing. A lot of very busy section. The bone metaplasia is noted. We can see, angulated, irregular, ductal, poorly formed ducts. The stroma is cellular. I'll go higher. In some areas, we can see some collagenization of the stroma, but then we see a typical mitosis, and we counted up to 10 mitosis per 10 high power fields. Again, this is just another section of the same thing, highlighting at the left side of the screen and what look more like busy proliferation of tubular ducts. And then on the right side is more of the tumor. So this is more in the vicinity of the tumor, where we can see the pale looking tumor at low power. Same thing, irregular ducts that are just, having abnormal shapes, not well-rounded, and a very hypercellular stromal background. Some of the ducts at some portions had this squamous or squamoid metaplasia, pretty obvious on H and E with apoptotic figures. Again, a higher power showing mitosis. The ducts, now if you look closely at these ducts on H and E, I mean, we're going to get to the stains very soon, but then you're not very convinced that there is myoepithelial cells at, or maybe this could be one. So it was a very busy slide and difficult to really decide whether these epithelial components are benign or malignant. So we'll go to the H and the stains, the immunostains. In this slide, just showing the contrast between the normal or the normal appearing ducts on the left side, basically adenosis, and on the right side, much of the tumor. Here, on the core biopsy, there were areas that looked like collagenous cirrhosis. On the excision, not so convincing. These are more of fibrovascular cores there. These are, some, epithelial cells forming around hyalinized cores. But just to show that it's kind of different from the major part of the tumor. Again, we have this bone metaplasia, just another slide showing the same thing. So let's go to the H and E. We did triple stain. We can see the, I'll just go to the high power because the time is limited so that we can kind of tease out the cells that are proliferating in this tumor. So we can see from this triple stain, P60, so the ducts, which are positive pink CK19, we can see they're all rimmed by myoepithelial cells, which are, this is CK19, SMMS, and P63, nuclear P63. But interestingly, we can see in the stroma, you can see the normal stromal cells, which are not picking any stain, but you see these spindle cells in the stroma, which are picking myoepithelial stains, that's SMMS and P63. Still on higher power, or let me go back first. On this, you can see some of the CK19 pink, cells. So you don't know whether they are, infiltrating epithelial cells or, compressed ducts. Now, at another section, we see the epithelial cells that are not rimmed, or maybe you can say this is one P63 positive myoepithelial nucleus, but at least one is these ones are convincingly devoid of myoepithelial cells. And here it looks like a mix. that was the area of squamous metaplasia showing positive P63 stain. And here, just thought it was interesting to see some of the non-staining, this is still triple stain, non-staining stromal components forming some nodules. And we can also see the myoepithelial stains and the pink P63. This is CK7, which is meant to stain only the luminal cells, that's the luminal epithelial cells. And you can see how they are scattered, and one found it difficult to decide whether these were benign or malignant epithelial components. Here is also CK7 showing the contrast between the area that looked obviously benign on H&E and the area of the tumor that was more irregular. We can see CK7 staining the luminal component. I have a higher magnification of this at the last slide. We can see staining the luminal component, and if you can imagine or you can see with an eagle's eyesight, the myoepithelial cells are not staining. And same thing in the benign looking portion, the luminal epithelium staining.
Code brown, level 6.
This, in contrast, CK5, which is a myoepithelial stains the myoepithelial cells, and which we can see scattered in the stromal background. So many of them are also spindly like myoepithelial cells. And the ductal epithelial cell, the tubules that we saw and positive for CK7 are clearly negative for CK5 here, negative for CK5 here. In the benign looking portion, we have the CK5 staining myoepithelial cells and not staining luminal epithelial cells. I did another myoepithelial stain, which is calponin, and some of the dots picked up the calponin. So, and so this, well, CD117 was just patchy. I want to come to this kind of put a high power for all the three, the two myoepithelial stains and a luminal CK7. We can see calponin staining myoepithelial cells. The luminal cells are negative, and CK7 is somehow or somewhat opposite, and CK5 was almost like the calponin. So as you will imagine, there was a struggle to decide what was going on. What are the neoplastic cells? Are they the ductal epithelial cells or the myoepithelial cells, or indeed the background stromal cells? But so this case was sent widely in consultation, and incidentally, the descriptions were not identical. There were different views, but everything. I mean, eventually the different views pointed, even though there were variations in interpretations of the slides and what was positive, what was negative, but the description went to the same diagnosis. So, but in summary, we have the spindle cell component. So there are three components that I'll try to, elucidate: the epithelial component, myoepithelial component, and then the stromal background. The spindle cell components was predominant in this lesion. We saw that there was heterogeneous. Now, this is a summary of one of the consults. But this recognized two types of spindle cells. Some were bland, low cellularity, mixed and focally collagenized stroma with ossification. And then there were areas where it was atypical, highly cellular, frequent mitosis, and they were epithelioid. The entire was well circumscribed. And this also described the epithelial component as different, and conclusion here was that it lacked malignant features. And so if you go, at high power, there were no cytologically malignant features. Epithelial components were noted to be more of strands of cells or small glandular formations surrounded by myoepithelial cells. As I showed, there was focal areas of metaplasia. Now, most of us will be thinking now whether it's a metaplastic carcinoma, and the question has to be answered whether the spindle cell components are expressing epithelial markers, which is what many of us we used to call a spindle cell proliferation in metaplastic carcinoma. And this was the direct quote of one of the comments. Said evaluation of the spindle cells for expression of epithelial and myoepithelial cell markers on immunohistochemical staining was difficult. Small compressed gland mixed with spindle cells. However, the spindle cells appear to show variable staining for these myoepithelial stains. So P40, P63, CAM 5.2, CK5, SMA, and SMHC. And then more focal staining for calponin, another myoepithelial stain. CK7, that's epithelial pankeratin. And then very focal staining for AE1, that's pankeratin. Now, the spindle cells were negative for ER, PR, and HER2. This was another interpretation of the myoepithelial cells, another sort of the spindle cell component, and this another consult. The positive stains were SMA and CD10. These went, I mean, we're talking about the stain in the spindle cell component. Most people agree that the epithelial component was, likely benign. Spindle cell components were negative for epithelial markers. All these were negative. Now, so summary, I mean, it was a little bit not too, distinct, but at least we can all summarize these features. One, there was a malignant spindle cell component, possible focal expression of epithelial markers, benign epithelial cells. Now, I don't know if everybody will agree with benign epithelial components. I showed some places where there were lack of myoepithelial cells in the clusters of epithelial components, and then there were other areas where even the morphology itself, angulated, scattered, where those spindle where those myoepithelial spindle myoepithelial components expressing epithelial markers. We don't know, so I don't think everybody will agree that they were completely benign. There was also heterologous osteochondral differentiation, and the adjacent areas that I was trying to describe was actually adenomyoepithelioma. So putting all this together, there was this list of differential diagnoses, and first was malignant phyllodes tumor, which was what was favored on the core, but that's, I mean, I'll put a thumbs down for that eventually because of these features. No leaf-like architecture, no stromal overgrowth, no prominent slit-like duct. So I usually imagine fibroepithelial, typical medical student description of fibroepithelial proliferation is compression of those ducts, expansion of the stromal component, there was no obvious periductal stromal condensation. Now, metaplastic carcinoma was a strong differential, including low-grade adenosquamous carcinoma. Malignant adenomyoepithelioma was also a possible differential. I will describe that a little later. Now, myoepithelial carcinoma. Most people agree that the myoepithelial components from this expression of stain and the morphology looked abnormal, but if you think that the epithelial component was also abnormal, you will call it an epithelial myoepithelial carcinoma. Primary breast sarcoma was also a differential, but that will not have, it will be a pure stromal tumor, and that was not the case. Metastatic spindle cell tumor was also considered, but very rare, and that was not the case. Final diagnosis from most all the consults and the features was actually a malignant adenomyoepithelioma. Now, somebody described it as metaplastic carcinoma arising in association with adenomyoepithelioma, which is also the definition, or which is by definition, a malignant adenomyoepithelioma. Now, it was the malignant component was ER negative, PR negative, and HER2 negative, but there was an initial interpretation of positivity because that's a biomarker positivity because the epithelial component was not, recognized as benign. So those who recognize it as benign eliminated it from the assessment of biomarkers. So that was the final diagnosis. I'll just, in the next, I don't know how many minutes I have left, but I'll run through epithelial, myoepithelial lesions of the breast, and then we'll take comments. Currently, this is the best classification of myoepithelial lesions. You can be benign or malignant. Benign components are AME and pleomorphic adenoma. Malignant are adenoid cystic carcinoma and malignant AME. Some people call that AMEM. Not included in this metaplastic carcinoma. This is a purely epithelial neoplasm, not an epithelial myoepithelial neoplasm. And phylloides tumor, which is an epithelial and stromal, not necessarily epithelial, myoepithelial. It's an epithelial and stromal neoplasm. Sarcomas are obviously stromal neoplasm. That's why I was stressing the 3 different lines of histogenesis in this tumor. Now, AME was first described in 1970 in WHO 5th edition. They are classified under breast tumors. And there was an attempt to harmonize it with AME of the salivary gland, which is always malignant. But there are notes that in the breast, you can have the benign component, which is pure AME, and that's distinguished from the AME with carcinoma, which is AMEM. Now, benign AME is usually indolent, local recurrence, malignant transformation, and distant metastases have occurred. And there's a proposal to call this atypical AME. So well, I just came back from the USCAP update in Sweden, and there was a lot of talk about the 6th edition of the WHO, and that this has been accepted in the 6th edition. That's the inclusion of an atypical AME. Now, so for pure benign AME, you don't expect to have these, features. I will also point out some morphologic features later. AME itself, by histology, is notoriously heterogeneous. The heterogeneity is both molecular and morphologic. I'll just point out here that ER positive and ER negative AMEs usually have different genetic mutations. Now, the atypical, I prepared this presentation over a year ago, so I should have removed the word. Well, it's still proposed, even though it's been accepted. But atypical adenomyoepithelioma is mild to, we call it atypical when we have mild to moderate cytologic atypia. We have mitosis between 3 to 5 per 10 high power field. If it's less than 3, it's still benign. Then necrosis, those are things that will make you call atypical. Now, the malignant form is actually thought to arise from transformation of a pre-existing benign AME. That's why it's crucial to see the benign component in the vicinity. That's what helps in making the diagnosis of malignant AME. It's an epithelial, the malignant component can occur in the epithelial or myoepithelial portion of the lesion. If it occurs in both, it's called an epithelial myoepithelial carcinoma, as I imagine we all know. Features of malignant transformation include cytologic atypia, increased mitosis, and necrosis. Histogenesis, what's the cell of origin?
Sorry to interrupt, Polycarp. So just for the purpose of time, would you mind maybe wrapping up in a, if that's okay. Thank you so much.
Okay, I'm going to round up now. I'll just go to the last slide. I think, so we have epithelial component can be in situ or invasive. If it's in situ, you call it with DCIS. If it's invasive, it can be any of these known kinds of tumors. This proposed classification was rejected by the WHO panel. These are myoepithelial markers that are used. And finally, my last slide is just a summary. So AME malignancy, morphologic biphasic tumor, presence of benign AME component helps to clinch the diagnosis. You need a lot of immunostains to do that. It may be difficult or impossible to distinguish from metaplastic carcinoma, and the management is complete excision with axillary dissection. Thank you.
Thanks so much. Very complicated case. Thank you so much for your presentation. We might have time for maybe one quick question before we move on to the next presentation. Okay, so we'll move forward with the next presentation. Thank you again. So the next presentation is from Dr. Sonal Varma from Kingston Health Sciences Center.
Okay, so this is a 48-year-old female. She presented with a painful palpable lump. She noticed it a month ago, but not sure how long it was there for. And so here's the mammogram. They did a tomo because it was very hard to see. So here it is at the far sort of posterior part of the lower inner quadrant, more medially on the left breast. And here it is on the diagram that the radiologist draws. So that's the mass there. And it was 1.9 centimeters non-calcified mass. And on ultrasound, it was a little bit smaller, but tomo wasn't fully able to delineate it. But you can see here that it looks stellate and the ball is not encapsulated and it's infiltrative looking. So this was called a BIRAS5 lesion and highly sort of suspicious for malignancy. And here it is on the ultrasound, and that's the palpable area. The other breast was completely fine. So here's the low power view. Just we got the 1.9 centimeter mass, but it was so posterior that they had a hard time biopsying it. So we got fat and fibrous tissue at this power, but you don't see anything obvious glandular or neoplastic going on at this power. But when I go to a little bit higher power, you can see these very bland looking foamy cells in the stroma with some fibrosis, which can be easily mistaken for a histiocytic reaction with fibrosis, maybe scarring. But what catches your attention at this point is that these foamy cells have, if they were histiocytes, they shouldn't have these round central nuclei. Histiocyte nuclei are usually very crooked and spindled, kind of like this, but most of them had a lot of granular cytoplasm with rounded sort of central nuclei, and nuclei have smooth borders. So that is kind of odd for a histiocytic lesion. So I did the stains, and sure enough, it's CD68 positive, but these granules are DPS positive in the cytoplasm. And then you look at SOX10, which is diffusely positive, S100 is positive, and here's a close-up of SOX10 as well. So this is a histiocytic looking lesion with granular cytoplasm, rounded nuclei, SOX10 and CD68 positive at the same time. So it's a granular cell tumor of the breast. Majority of them are benign, and surgical excision with complete excision is curative. Rarely you can see local recurrence if it's not completely excised, but usually if they're under 5 centimeters, they tend to behave very nicely. It's now suggested that it's a nerve sheath Schwannian origin tumor, and that's why we see S100 SOX10 positivity in them. They can be multicentric, but that doesn't mean that they're malignant, because it's just the way it grows that it has multiple different nidus that it's arising from, rather than truly metastatic or vascular invasion or something like that in the breast. So they are usually single, but sometimes they can be syndromic with like Noonan syndrome or Leopard syndrome or things like that, but usually then present at a younger age. Malignant criteria, we don't know for sure, but anything over 5 centimeter, be very cautious in calling it benign. Some people say more than 2/10 mitoses is criteria for malignancy, with the necrosis and more atypia. And some people even say that just the presence of metastases is condition for being malignant, which it's too late, I believe, by then. But anyways, I haven't seen any good metastatic case reports or studies in the breast. So just to summarize, the positive stains are, the main ones are S1 isoxasten CD68, but there are a few other stains that can be positive, including calretinine. So if it's posterior and you're wondering, chest wall mass versus a breast mass, calretinine may throw you off. So doing multiple stains will be helpful. Negative stains from ERP are negative. So even though these occur in premenopausal women and sometimes perimenopausal, they have no hormone kind of growth pattern. So their ERP are negative. And then, you'll do multiple stains to make sure nothing else make sure that it's not a melanoma or other things, depending on what you say. And that's pretty much it for my case. Happy to take questions.
Thank you, Dr. Varma. I think you probably went over it, but I might have missed it. Could you let us know again the radiologic or the presentation of this patient? Was it a radiographic abnormality that was concerning for cancer?
Yes, so she had a palpable mass, and that's why she came to the breast clinic. And on ultrasound, she had this correlate in the lower inner quadrant. And that's the other thing. These things usually develop along the cutaneous sort of branches of supraclavicular nerve. So they tend to be more lower inner, or sort of medial aspect of the breast rather than outer aspect, as the cancers usually are. But she had a BIRATS 5 because of that stellate nature. She had a BIRATS 5 classification.
Great, thank you. We have a question from Dr. Mulligan.
Thanks, Rachel. Great case, and subtle enough, I would say, on histology. But we don't use HBS here. I guess that's what I was looking at, but it's a while since I've seen one. And it's actually very nice to see the contrast, right, between the cells and the adjacent stroma. So I've a question just about what we know about the natural history. I mean, most of these are benign. I've never seen a malignant one. I think it's very uncommon. So untreated or not excised, do these continue to grow? Do they regress? And I guess it's the only reason we excise them, because they tend to look really scary on imaging, and we just want to make sure that we have.
Yeah, and there is no study that I came across for malignant conversion. So I guess because we always take them out and they're so rare, we don't know about their progression.
Thank you.
We have a question from Kevin Kwan.
Okay, yeah, thank you for the presentation, Dr. Varma. Earlier I see on your PowerPoint, it's saying that TFE3 also stains 91% of the tumor.
Yeah.
Like, do you know if that's associated with the molecular alteration, or it just so happens that it stains it?
No, it just stains it. So benign ones stain it too.
Interesting, cool.
I've never used it. We don't have it, but that's what the studies are showing.
I see. Thank you.
And maybe I should do. I think I did TRIPS one on this. I'll double check.
Yeah, that would definitely be interesting to see. Thank you so much for sharing that case, Dr. Varma. Our next case is from Dr. Boris Farine from Sunnybrook Health Sciences Center.
All right. So this is a case that actually Dr. Sladkowska did that I'll be presenting. It's a 61-year-old female. She had a history of a left-sided breast cancer in 2015, for which she had a lumpectomy. And that was done outside of Ontario, as far as we could tell. Subsequently, in 2024, she presented with a chronic cough lasting for about 6 months. She had CT chest to do imaging, where they found bronchial wall thickening and incidentally discovered a left breast spiculated opacity. So they decided to follow up on the opacity, first with a mammogram and ultrasound, which showed two areas that were suspicious. One was near the left lumpectomy scar. There were two adjacent hypoechoic masses, quite small, 4 and 5 millimeters respectively. And then left lateral spiculated mass, which was 7 millimeters in size and 16 millimeters from the lumpectomy scar, which likely correlated to the CT findings. They followed it up with an MRI, which showed hypoechoic nodules adjacent to the scar, corresponding to likely low axillary lymph nodes. And so those were likely the two small masses, the 4 and 5 millimeter ones. Whereas the lateral mass likely corresponded to a circumscribed progressively enhancing mass. And so they ended up doing biopsies of all the lesions, and the one that's most relevant to us is the MRI biopsy that they did of the lateral mass. And so this is what we see at low power. So it looks like fibrous tissue with a lot of pigmentation. And then at higher power, there's still all this black pigment, and there are a bunch of epithelioid cells kind of interspersed throughout. And so we did a few stains to characterize these cells. They were keratin and SOX10 negative and CD163 positive, in keeping with histiocytes. And so this is a difficult diagnosis to make at this point because it seems to be benign and reactive in some way, but we weren't sure what this pigmentation was. And so after showing it around, the conclusion we came to was that this was likely in keeping with a charcoal-induced granuloma. And so these can be associated with charcoal injections, which are done for tumor marking. Some places will do them for instead of wire localization. And so the challenge with these cases is that radiologically, they can mimic invasive carcinomas, and they often occur adjacent to the initial lumpectomy site. And so they can get biopsied and cause a lot of distress for the patient, and can be potentially challenging histologically as well. So the question then for our patient is whether or not she had any charcoal injection. We know that she had a prior lumpectomy in 2015, and we know that she previously lived in Nova Scotia because a note had said she had a respirologist there. And so we went to see just if there was any potential history, and it does look like around this time in Nova Scotia, charcoal injections were used. So it's possible that this is what we see, though we can't confirm for sure. And just in general, when encountering cases like this, things to keep in mind are that charcoal-induced granulomas can mimic breast carcinoma radiologically, as well as melanomas histologically, and that it's something to keep in mind when we see these rare pigmented lesions with epithelioid histiocytes. We also wanted to thank Dr. Mulligan. Dr. Sadkowska said that she was the first one who came up with this diagnosis. So thank you very much, Dr. Mulligan, and thank you everyone for listening.
Thank you, Boris. That was a very interesting case. Don't know if I missed it. So clinically, did they talk about being able to see this lesion?
It was just radiologically observed. Yeah, so it was incidentally identified on the CT and then subsequently seen on ultrasound and MRI.
Thank you. Dr. Mulligan?
Thanks, Jessie. Thanks, Boris. I'm certainly not an expert on this, but I had seen images of something similar a few years ago, and that made me to wonder whether this was it when Elzbieta shared the images, but I'm sure Dr. Barnes is far more experienced in this. I just have a question, Boris. When you were reading around this, obviously it's used to localize the lesions. So in the excision specimen, what are the immediate effects of the charcoal? Does it like interfere with interpretation? Does it cause like early changes? It's just, we get used to our own, iatrogenic effects, right? So like for the Molly seed that I think many of the centres are probably using now in Ontario, I've noticed that if there's an interval between putting in the Molly with the excision, that it can lead to quite impressive cytologic changes that can be quite concerning. Just wondering about, the charcoal, does it cause anything in the immediate situation?
I'm not sure. Usually it does get removed with the lumpectomy specimen. But I didn't see anything described, at least in the review that I did, of it causing any sort of diagnostic challenges on the lumpectomies. It's just because of the subsequent residual charcoal left over, it can cause a reaction in the long term. But yeah, sorry, I couldn't answer in more detail.
Do you know how long the interval normally is before it, causes imaging concerns?
I'm not sure.
I see Dr. Barnes has her hand up, so perhaps Penny can.
Yes, I can comment on this. So back in the early 90s, when Nova Scotia set up its screening program, the lead radiologist introduced injecting carbon along with the contrast medium at the time that the core biopsy is taken. And this is something that's done in Scandinavia for FNA. And so this has been done for decades. Now carbon is injected along with a clip much of the time. And it's not used to localize. So the radiologists still put in a seed or a wire, now more often a magnetic seed, to localize. But what is really great for pathologists is to actually see this black line. It's very useful when you can't actually see a mass. So in cases of DCIS, you know exactly where the core biopsy came through, because sometimes clips can transport during compression. So this is just a way to track the area that's been sampled. But you're right that once in a while, it does cause a granulomatous reaction. So over time, I think what's happened is that they inject less and less of the carbon, so very little is needed to be able to see at the macroscopic level. And sometimes we do see a sarcoidal reaction where patients with sarcoidosis develop this kind of intense granulomatous reaction to the pigment. So I don't know if this is unique to Nova Scotia, but but in pathology we find it very helpful in sampling non-mass lesions that have been excised.
Thank you, Dr. Barnes.
There's another comment in the chat section. It's relating to the use of charcoal. So there's a question about, was the patient using charcoal-related products which caused breast carcinoma, or was she exposed to charcoal in the work environment?
So there were very few clinical notes for this patient. So I don't know. We looked for it because it would have been interesting to see, but as far as I could tell, the most likely cause of this finding was probably from charcoal injection.
Fantastic. Are there any other questions? If not, well, thank you, Boris. We'll move on to the next presentation by Dr. Hafiz.
Hello, everyone. I'm Ben Hafiz, breast and gynecological fellows at National Guard Hospital in Saudi Arabia. I'm pleased to present today one of the interesting cases in our institution. The case about 43-year-old female, which is who's newly diagnosed in another hospital with breast cancer, and case sent for us for consultation. And if you would like, you can scan this barcode to visit the virtual image. But I will go through the still image. Here we can see the core of lesional tissue. There is no residual normal breast parenchyma. This lesional tissue composed of a sheet of polygonal cells with clear to eosinophilic cytoplasm, and we can see here some papillary-like growth. In high power, we can see these cells have round nuclei with voluminous clear cytoplasm, and also some of the cells have this eosinophilic cytoplasm, and we can appreciate the nuclear grade morphology. Through the lesion, there is no mitotic activity. Here in another area, we have this papillary growth pattern with the same nuclear morphology. Also here, along with these slides, we received the hormonal biomarkers. Here in the ER, we can see there is focal staining areas that are that is positive. but they from the outside institution reported as negative. Also, the BR, we have the same staining pattern that in the ER, but also it is reported as negative. Here too, negative, there is no staining, score 0. So, and the Ki-67, it is low proliferating index. So outside my diagnosis was invasive mammary carcinoma with secretory features, histological grade 2, and they label it as triple negative carcinoma. And they suggest more in their comment, it could be secretory carcinoma. Then the patient underwent breast mastectomy and sentinel lymph node. Also here the barcode for if you want to visit the virtual image. This is the lesion from the low power. We can appreciate the periphery, which is circumscribed and relatively demarcated with thin fibrous capsule. Also, the lesion is lobulated. Here, other view from the low power. No, in the intermediate power, we can see the same morphology that we saw in the core biopsy. We can see the papillary architecture or papillary growth pattern with these solid nests in between that are composed of these clear to eosinophilic cytoplasm, and here more of clear cytoplasm with low-grade nuclear morphology. The same morphology along these sections. And interesting, there is one section we can see this area of tubular formation that filled with eosinophilic secretions. So after this morphology, we have to prove the nature of the lesion and perform additional immunohistochemistry to characterize the lesion. We did CK56 and B63. And CK56 and B63 shows diffuse staining in the proliferation in the proliferated area in between the tubules and gland. And we ordered also many epithelial markers, CK7, which highlight the epithelial area. EMA also highlight the small tubules. And the AR shows the same pattern that we saw it in the core biopsy. We have this focal area that highlight the luminal and epithelial areas. This is CD34, CD31 to highlight the vascular areas. In summary, we have this biphasic tumor with epithelial and myoepithelial proliferation, and we have positive epithelial marker, myoepithelial marker. So the diagnosis ends up as adenomyoepithelioma. I will talk briefly about adenomyoepithelioma. It is a rare biphasic neoplasm with the epithelial and myoepithelial proliferation. It's described first at 1970 by Hamper. It's benign lesion, but the malignant transformation may occur either from luminal or myoepithelial component or both of them. It commonly occurs through in the elderly women and rarely reported in males. Usually present as a palpable nodules and with ranging in size and reaching even up to 10 cm. In the pathogenesis, it's classified based on ER status, ER positive, ER negative. PIK3CA present in both subtypes, ER positive and ER negative. But ACT1, it is mainly associated or mainly present in the ER positive, HRAS and CDKN2A in the ER negative cases, and these are associated with epithelial myoepithelial carcinoma in salivary gland. Also, the CDKN2 associated with increased recurrence rate for malignant adenomyoepithelioma. Usually present as circumscribed nodule with pushing border or margin. Microscopically, adenomyoepithelioma, it is well circumscribed and may be encapsulated with dual proliferation of epithelial and glandular lumen, and myoepithelial cells constitute the outer cell layers in between the glandular component. Morphologically, it's classified into tubular, spindle lobulated. Tubular have small round tubule lined by epithelial cells, are surrounded by myoepithelial cells, which typically have abundant clear cytoplasm. The spindle subtypes shows myoepithelial cells with a spindle morphology, which constitute the predominant component and surrounding inconspicuous epithelial nest and tubules. The lobulated subtypes shows prominent stroma, either collagenous, myxoid, or chondroid, and surround the two-cell population. Papillary areas are commonly seen in the adenomyoepithelioma, as in our case. Mitotic activity is typically low, less than 2 mitotic figures, and the cells are lacking the cytological atypia. Here, briefly for immunohistochemistry, for the adenomyoepithelioma, we have epithelial component and myoepithelial component. The epithelial component usually positive for low molecular weight, but we have specific pattern. If the high molecular weight taking in the epithelial, we have paradoxically stained the inner epithelial cells are positive instead of outer epithelial cells. Also, the epithelial cells positive for CAM5.2, EMA, CK7, and ER. The ER, it will take the luminal area. Myoepithelial markers will be positive in the myoepithelial areas, and these the myoepithelial markers. Carcinoma may arise from the ductal epithelial cells, myoepithelial cells, or both. And we have to name it as a malignant adenomyoepithelioma if we have pre-existing adenomyoepithelioma. And either we have epithelial, myoepithelial, or both of them. But if we don't have pre-existing adenomyoepithelioma with distinct epithelial and myoepithelial cell population, we will label this as epithelial myoepithelial carcinoma. And to diagnose epithelial malignant transformation, we have to have high mitotic activity, marked cytological atypia, and necrosis. Distant metastases to lung, brain, and liver also have been reported, and usually malignant adenomyoepithelioma spread through the hematogenous routes other than lymphatic routes. This is the important slide in this presentation. Due to heterogeneity in the appearance of adenomyoepithelioma, the adenomyoepithelioma is a challenging diagnosis in core needle biopsy and can mimic many entities in the breast, either benign or malignant, due to multiple heterogeneity and dual proliferation and multiple growth pattern. The most common differential diagnosis is intraductal papilloma, and at the first time of diagnosis, it was considered as a type or subtypes from intraductal papilloma, and then they separated into another entity. Also can mimic tubular adenoma, carcinomas, phylloides, and salivary gland tumors. And we will talk here because this, in our case, it's diagnosed the core biopsy as secretory carcinoma. This is how to differentiate between secretory carcinoma and adenomyoepithelioma. Clinically, the patient in the secretory carcinoma is usually young, but it is also affect wide age range. However, in adenomyoepithelioma, more the disease of the old age. Morphologically, secretory carcinoma shows solid cyst and gland formation with abundant vacuolated granular cytoplasm with intracellular secretion that are positive for pus stain. While adenomyoepithelioma is biphasic, composed of epithelial myoepithelial proliferation, and the myoepithelial proliferation usually have voluminous clear cytoplasm, and both of them have low-grade nuclear morphology. The hormonal markers in the secretory carcinoma, it's triple negative, where the adenomyoepithelioma shows the ER and BR usually have positive or negative, especially in the luminal cells, but it's negative in the myoepithelial cells. Here too, it will be negative in both entities. Immunohistochemistry, secretory carcinoma are positive for S100 in the tubular area, but the adenomyoepithelioma S100 is positive in myoepithelial cells. Secretory carcinoma negative for B63, adenomyoepithelioma is positive in myoepithelial component for B63. In the molecular part, secretory carcinoma shows ATV6 in TRAC3, while adenomyoepithelioma, as we mentioned previously, it depends on ER status, including these genes. Treatment-wise, secretory carcinoma treated surgically with surgical treatment and axillary lymph node, and the treatment adjuvant treatment depends on patient status. Adenomyoepithelioma, the benign adenomyoepithelioma, treated by wide local excision. Adenomyoepithelioma follows a benign clinical course with complete surgical excision. A peripheral intraductal excision, incomplete excision, and variable cytological atypia may be linked to local recurrence. Adenomyoepithelioma, it may be named as neoplasm of low malignant potential due to potential of malignant transformation and metastatic potential. So it's better to label it as neoplasm of low malignant potential. Adenomyoepithelioma treated by complete excision with adequate margin, and this treatment would lower the chance of local recurrence or potential metastasis. And the mastectomy and or breast conserving surgery with radiation and axillary dissection are not necessarily for the benign adenomyoepithelioma, but may be indicated for carcinoma that arising from the adenomyoepithelioma. Finally, adenomyoepithelioma is a rare biphasic tumor with potential for malignancy, can mimic many entities, either benign malignant, especially in core biopsy. So we have to be careful and careful examination in the core, in the histopathology and immunostaining, especially in the reporting the ER staining pattern. I have to be aware of the positivity of ER staining and pattern of ER staining. Complete excision is a key for accurate diagnosis, cure, and recurrence prevention. Thank you.
Thank you, Dr. Hafiz, for an excellent case presentation. Second adenomyoepithelioma case of the day today. Does anybody have any questions for Dr. Hafiz? I have a very quick question. So you mentioned that in this case, you had an ER low or ER negative tumor. And so I'm wondering at your institution if you would then pursue any of the molecular testing that you mentioned, so the HRAS or the CDKN2A?
Unfortunately, we didn't do the molecular on this case. We just rely on the morphology with the immunostaining pattern.
Great, thank you.
Thank you.
Great. Well, that wraps up our case presentations for today. Thank you so much for an excellent summer session of breast pathology community of interest. And thank you everyone for your attendance and for attending this meeting. A quick reminder that the feedback form has already been linked in the chat. But this will also be emailed to you as well, to the emails that you signed up for this link with. And please fill out the evaluation form in order to get CPD. Thank you very much.
And thanks, Rachel and Jessie, for organizing this wonderful session. And thank you to Dr. Anna-Marie Mulligan and Sharon Moses for an excellent expert opinion. And thanks, Dr. Barnes, as well. Thanks, everybody, and we'll see you soon for our new communities of interest that are coming this summer. Please follow up all the notes and emails. Bye now.